Welcome to the 39th Annual Charles W. Hartman Memorial Lecture. I'm Jeff Fitter, Chancellor of this great university, and I have the privilege of commenting on really what I think is one of the most enjoyable aspects of my work, which is bringing greetings on behalf of the entire University of Mississippi community. You'll hear more about Dean Charles Hartman from our pharmacy dean, David Allen, very shortly, about his vision, about his leadership, about his creativity and energy, charisma. And as a former dean myself, I especially appreciate today. Let me give you some examples. He spearheaded some trend-setting approaches to teaching academic issues that have established national norms. He led outstanding research and mentorship, scholarship, on many metrics, achieving a top 5 ranking nationally. And across the globe. For 43 years, we have honored Dean Hartman and his legacy with this distinguished memorial lecture series. And through the years, this lecture series has brought to campus amazing thought leaders from academia, government, industry, and nonprofit organizations. Speakers have included presidents of 2 universities, an FDA commissioner, the U.S. Attorney General, 2 U.S. senators, a governor, 2 pharmaceutical CEOs, and presidents of the American Medical Association and the American Heart Association. We're going to continue that tradition of excellence with today's most distinguished speaker, Dr. Paul Abramovitz, who's the CEO of the American Society of Health System Pharmacists. And that's especially appropriate and pertinent to me. My wife Sharon, who wishes she could be here, was trained as and worked as a hospital pharmacist. Dr. Abramovitz, we are honored with your presence here today, and to everyone who has joined us today, we welcome you to this very, very important event. Thank you all for being here.
Thank you very much, Chancellor. We're delighted that you're with us today. Well, good morning, everyone. On behalf of the Ole Miss School of Pharmacy, I would like to thank you all for attending our annual Charles W. Hartman Memorial Lecture. I would especially like to thank Chancellor Vitter for his welcome and attendance at his very first pharmacy lecture today. This lecture series began in 1973 to honor our school's 3rd dean, Charles Hartman. Dean Hartman's tenure was tragically cut short by an automobile accident 45 years ago. Today, we remember Dean Hartman for his many accomplishments on behalf of our school, pharmacy education, and pharmaceutical research. An Alabama native, he served as a pharmacist mate in the U.S. Navy and Marine Corps. He received his pharmacy and master's degrees from the University of Georgia. After receiving his PhD from the University of Florida in 1956, he joined the University of Georgia's Pharmacy and Pharmacy Administration faculty. 5 short years later, he became dean of our School of Pharmacy and set about taking it to new heights. He secured funds to construct Phaser Hall, which still stands today as one of our main buildings on campus on the Grove. He also created and maintained our Research Institute of Pharmaceutical Sciences, now a world-renowned institute that comprises 3 centers. We are in the process of establishing a 4th center, the Center for Clinical and Translational Science, which will further elevate the stature of our Research Institute. Dean Hartman's research interests range from drug absorption to pharmacy administration, and he was granted 8 patents related to his numerous investigations. He also was a consultant to the U.S. Public Health Service, vice president of the Mississippi Association for Mental Health, and active in the American Pharmacists Association and many other groups. Sadly, this champion of pharmacy, education, pharmaceutical research, and our profession was installed as Vice President of the American Association of Colleges of Pharmacy only 5 days before his death. Dr. Juan Bourne, a retired faculty member who's with us today, who was hired by Dean Hartman, said that he was a true visionary, a dreamer, a goal setter, a goal achiever, a doer, and a leader. He also said that Dean Hartman was a motivator who believed in us and had us believing in each other. It is undeniable that Charles W. Hartman left an impressive legacy and profound impact on this school. We are pleased to honor this legacy and to acknowledge Dean Hartman's many contributions to our school, our profession, and our state today. Please join me in acknowledging him with a round of applause. Now it is my great pleasure to introduce our guest lecturer, Dr. Paul Abramovitz. Paul is the Chief Executive Officer of the American Society of Health System Pharmacists in Bethesda, Maryland. Paul received his bachelor's degree in chemistry and biology from Indiana University, and then pursued a bachelor's degree in pharmacy from the University of Toledo. He received his PharmD degree from the University of Michigan and completed a residency at the University of Michigan Medical Center. He joined ASHP in 2011 after working in hospitals and health systems for more than 3 decades. He served as treasurer of ASHP from 2007 to 2010, and he also was president of the organization from 1993 to 1994. Prior to serving as ASHP's chief executive officer, he served as associate hospital director for professional services and chief pharmacy officer at the University of Iowa and its College of Pharmacy. He was also a professor at Iowa and is now a professor emeritus. Paul is an award-winning lecturer, having received both the John W. Ward Lecture Award in 2000, as well as the Harvey A.K. Whitney Lecture Award in 2009, which is health system pharmacy's highest honor. His other honors include an honorary degree of Doctor of Science from the University of Toledo and the Distinguished Alumni Award from the University of Michigan College of Pharmacy. He has a wide range of service efforts that include serving on the boards of the American Nurses Foundation, the Pharmacy Quality Alliance, and the Pharmacy Technician Certification Board, among many others. Paul has focused his lectures and publications on the effect that quality pharmacy care can have on improving outcomes of care and reducing costs, developing new care models, reducing adverse drug events, and expanding comprehensive pharmacy care to the ambulatory care setting, which I know Paul talks about as an amazing career opportunity for pharmacists. I'm beyond thrilled to hear from Dr. Paul Abramovitz today. Please join me in welcoming him to the lecture.
Wow. Chancellor Bitter, Dean Allen, student pharmacists, faculty, staff, and friends, good afternoon, and thank you so much for inviting me to give the 2016 Charles W. Hartman Memorial Lecture. I'm honored to be among those who have given the lecture since it was established in 1973. The University of Mississippi School of Pharmacy has a very, very long and rich tradition as a leader in pharmacy and the pharmaceutical sciences, and Dr. Hartman and the leaders that followed him played instrumental roles in making this the fine institution that it is today. It's amazing when you consider the vision that Dr. Hartman had for the profession of pharmacy, and without that vision, we would not be the very trusted, thriving, and patient-centered profession that we are in fact today. I'd also like to take a moment to recognize the dean of your great school, Dr. David Allen. David has been very involved in the profession and also with ASHP over the years, and is without question a bright star in pharmacy and pharmacy education. You're all very, very fortunate to have him as your leader. Like Dr. Hartman, Dean Allen and his stellar faculty lead with a long-range vision for Ole Miss and for the pharmacy profession. They see beyond the horizon and are helping to chart a path for pharmacy in the state of Mississippi and far beyond. Thank you, University of Mississippi, for your efforts to help the profession of pharmacy achieve its full potential by graduating some of the best students in the country and for leading by example. Now, I've used the term vision several times throughout this introduction. This was intentional because expressing a vision is a powerful way to describe where an individual, organization, or for that matter, a profession wishes to go in the future. A vision establishes long-range goals and serves as a tool to achieve those goals by inspiring and empowering others. Without a vision, the path is much less clear and there is little for us to rally around. Now, as I transition into talking to you about my vision for advancing pharmacy practice in ambulatory care clinics, I ask that you keep an open mind to new opportunities and many yet to be seen future realities that have and will face the future of pharmacy and our profession. Also, I'd ask that you challenge conventional wisdom and seek to be part of creating your future in pharmacy practice. I'd now like to talk to you about a vision for pharmacists as essential direct patient care providers in all ambulatory care settings. And my hope is, by the end of this talk, you will not just share this vision, but you'll embrace it, improve upon it, and advance your vision on behalf of the patients that you serve. Recognize that first and foremost, everything we do as pharmacists is for our patients, and nothing should compromise that. So let me be very clear right up front. I believe that many more pharmacists should have their practice sites in ambulatory care clinics than that which exists today. The rest of the healthcare team practices in clinics, and pharmacists should be practicing with them. If the pharmacist cannot be physically located in a traditional clinic or physician office, then they should be connected closely to the healthcare team in that clinic in other ways, and we'll talk a little bit more about that in a few minutes. Now, this will likely require a significant shift in the current practice of many pharmacists as we advance to achieve this vision, and it will also require many enabling factors. Please understand that a change like this will not occur overnight, but it will evolve over time. I believe that most of the community pharmacists practicing today within traditional pharmacy settings will have their practices transformed dramatically. Therefore, I envision a future where the majority of all pharmacists' collective practice time will be devoted to the provision of direct patient care, with only a relatively small percentage of your time spent managing the drug product. Thus, pharmacists would practice, if you will, at the top of their licenses in every ambulatory care setting. Now, you might call this idealistic and perhaps even unattainable, and you might be right about that today or right now at this point in time. But what you might not be able to dismiss is the fact that patients need pharmacists to achieve optimal medication therapy outcomes, prevent medication-related harm, to control disease, and to maintain their good health. And all of this today is highly dependent upon appropriate and effective use of medications, or in some cases, avoidance of their use. Furthermore, there is simply no other healthcare provider who has the optimal level of expertise in this area. In a world where medication-related problems continue to cause so much preventable harm and cost billions of dollars each year, due to suboptimal therapeutic outcomes, hospital and clinic admissions, and other factors, pharmacists must step up and be thoroughly included for their expertise on the ambulatory interprofessional team. This inclusion, I believe, should be similar as it now exists in care models that we have established in many of our hospitals, where the pharmacist practices as part of the interprofessional team based on the patient care unit and is enabled to shift the majority of drug preparation and dispensing to very well-trained and certified pharmacy technicians and others. Now let me further make the case for this vision. First, the prevalence of people with chronic conditions is increasing due to a variety of factors, including the aging of the U.S. population. Medications, as I mentioned, play a critically important role in the care of people with chronic disease. Medication use is becoming even more complex with advances in scientific discovery and a movement towards precision medicine or individualized medicine. The evidence demonstrates that medication use is not optimized in our current approach to healthcare. Physicians' capacity to effectively manage complex patients' medication regimens is limited due to a number of factors, many beyond their control. Reimbursement is now being tied to quality measures that relate directly to effective medication use. And of course, there is a preponderance of evidence supporting pharmacists' abilities to positively affect patient outcomes through our involvement in the therapeutic decision-making process, monitoring, and education related to medication use. Therefore, now is the time for all of us as pharmacists to lead a transformation of the healthcare system that will require many more pharmacists participating on clinic or ambulatory patient care teams as the drug therapy specialist who is responsible and accountable for the full spectrum of appropriate medication use. Now, assuming we might agree that there should be pharmacists in or connected to most ambulatory clinics, let's now make sure we all have a common understanding about what an ambulatory clinic actually is. So for the purposes of this discussion, I would define an ambulatory clinic as any primary care or specialty, physical or virtual setting, where a team of healthcare professionals work together to provide healthcare for patients outside of the traditional hospital inpatient settings or settings similar to that. All members of the team may not practice in the same physical location, but must be interconnected and interdependent. Ambulatory care clinics would include primary care settings where acute and chronic conditions are diagnosed and managed. It would also cover the full range of specialty clinics, such as cardiology, psychiatry, oncology, pediatrics, and of course the many others. Clinics might be defined as including physician offices, ambulatory clinics owned and operated by hospitals or health systems, accountable care organizations, patient-centered medical homes, community health centers, and others. In addition, we're beginning to see traditional retail pharmacies, particularly some of the large chain pharmacies, developing models to provide primary care. In fact, Walgreens has been testing what they call the well experience in about 600 stores where pharmacists are playing a much more integral role with patients. I include these in my definition of a clinic and use them as an example of one way that community pharmacy practice will change. CVS Health, which operates 1,100 minute clinics, has partnerships with 70 health systems around the country, which includes the ability to access the electronic health records of those health systems for the patients that they treat. Further, you might have seen the March 17, 2016 article in Hospitals and Health Networks stating that the retail clinic is becoming the new front door to healthcare. And internet-based healthcare providers like MeMD and Amwell and many others, where a patient can be seen and diagnosed by a physician by webcam, should include or connect with pharmacists as part of that patient's care management. Thus, it's extremely important that we think beyond the four walls of our traditional clinics, our provider offices today, and our traditional community pharmacies as we plan for and create our future. Many new and creative models and methods will be developed so that we can give all of our patients and other members of the healthcare team the access they need to pharmacists within the financial constraints of our healthcare systems. With a vision and with dedication, perseverance, and commitment, I'm completely confident that we can do so. The ways that we achieve this will be varied. Many new models that have not yet even been conceptualized will one day become the standard of interprofessional care. Now, in order to create our future, it's important that we appreciate the past. The concept of clinic-based pharmacy services is certainly not new and dates back to the Indian Health Service in the 1960s. And I would refer you to a recent commentary published by Janet Carmichael and Deanne Hall in the December 2015 issue of the American Journal of Health System Pharmacy. It's entitled Evolution of Ambulatory Care Pharmacy Practice in the Past 50 Years, and provides an exceptional summary of advancements in ambulatory care pharmacy clinics and community pharmacy. In addition, I would refer you to a second commentary, this one published almost 30 years ago in AJHP in 1987 by Janelle Mansour and myself, entitled Moving Towards the Provision of Comprehensive Ambulatory Care Pharmaceutical Services. This was 30 years ago, and at that time we made the case that comprehensive ambulatory pharmacy care was necessary and should be greatly expanded. We outlined our rationale at that time, which included these now 30-year-old facts. The complexity of drug therapy in the ambulatory care setting is increasing. Many new drugs are being marketed, making rational selection of drug therapy very difficult. Patients are being discharged from hospitals earlier, often on intravenous therapy. Self-directed care is increasing. Adverse drug events cost the nation's healthcare system at that time about $5 billion in hospitalizations, and it was estimated that 78 to 80% of those adverse drug reactions were both predictable and preventable. Medication compliance problems were huge. The elderly population was increasing, and we said at that time there is a need for one professional to be responsible for monitoring all aspects drug use in the ambulatory care setting. Now, do not all these points made 30 years ago sound very familiar to those I talked about a little earlier in this talk? To make the case for the rationale to advance pharmacy practice in ambulatory clinics? However, now the complexity and costs of medication therapy and its effects have increased much, much more significantly. We should, however, celebrate the fact that pharmacy practice in ambulatory clinics has in fact advanced substantially from that which one can reflect upon 30 years ago. We now see many, many more pharmacists practicing in clinics, particularly those associated with hospitals and health systems. Pharmacists participate as part of the team in many primary care and specialty clinics. The model is that we're often embedded in those clinics, review all patients' drug therapy, select those patients that the pharmacist believes that they need to spend time with to improve care outcomes. In many of these clinics, pharmacists are given enhanced prescriptive authority by physicians under collaborative practice agreements. And in addition, we have many patients who are referred to pharmacist-managed disease-specific clinics. And many of these clinics were set up many years ago by faculty at the University of Mississippi. in and around the state of Mississippi. Now, these are very common in areas of anticoagulation, diabetes, hypertension, asthma, hyperlipidemia, to mention just a few. We're also seeing the growth of pharmacist-managed wellness clinics, particularly in the areas of smoking cessation and others. And finally, many hospitals and health systems have established what have come to be called pharmacotherapy clinics or medication therapy management clinics, where patients are referred to be seen by a pharmacist when their drug therapies are complex, outcomes are not optimal, adverse drug events have occurred, or in general, the healthcare team believes that these patients need more intense monitoring and following by a pharmacist. In these clinics, pharmacists also schedule appointments for patients to be seen, to have their drug therapy managed in a very comprehensive fashion. It should be noted that in some of these clinics, much of the responsibility for the management of medication therapy, including assessment of outcomes and responsibility to achieve therapeutic endpoints, is given to the pharmacist. I hope I'm making the point that the scope and depth of pharmacy care in the ambulatory setting, particularly in clinics, has increased substantially. For more on the current role of pharmacists in ambulatory care, I would refer you to the Surgeon General's report entitled Improving Patient and Health System Outcomes Through Advanced Pharmacy Practice, which was written by Rear Admiral and former Chief Pharmacy Officer of the Public Health Service, Scott Giberson, and also to the many other examples of this in our literature. The question now is, however, what does the future have to hold with regard to having a pharmacist in or available to every ambulatory clinic or setting where medications are prescribed or monitored? In 2010, the ASHP National Survey of Hospital and Health System Pharmacies showed that 24% of hospitals with ambulatory services had pharmacists practicing in at least some of their clinics. And the survey in 2014 demonstrated that increased to 42%. Now that's a very impressive increase. It does portend well for the future, but we have a long way to go. I believe that the expansion of ACOs, medical homes, and other models of care will hasten this increase. In addition, the increasing number of very integrated multi-hospital systems and the growing number of physician office practices being purchased by these hospital systems should allow a further dissemination of the important role of the pharmacist in ambulatory care and thus hasten expansion. Also, many new and innovative ways to virtually connect pharmacists with their patients and the entire healthcare team will continue to emerge. Now, in order to enable that we have a workforce capable of providing comprehensive drug therapy management to all patients who require it in the ambulatory care setting, the pharmacy profession has really stepped up and made significant changes in education and training. This includes the Doctor of Pharmacy degree, advanced or accredited residency training programs, board certification, and training for pharmacy technicians and certification for pharmacy technicians. Healthcare systems have also begun to establish reliable ways to validate pharmacist credentials and grant privileges similar to that of physicians and others. Credentialing and privileging is often used to establish an advanced scope of practice for pharmacists in these health systems. It's very powerful and compelling when physicians, nurses, and other healthcare professionals see that pharmacists have the training and competency assessment they need to provide these advanced services. Additional enabling factors that we've been able to put in place include enhanced use of automation and advanced information systems, which effectively reduce the pharmacist's required time in medication preparation, distribution, and dispensing. And this has occurred to a very large extent in many of our hospitals, and I'm sure in your education you've seen this. This has enabled pharmacists' time to be transferred to the provision of direct patient care. The application of automation has also occurred in our community pharmacies and ambulatory clinics, but much further growth is needed, as is a much more comprehensive use of those well-trained and certified pharmacy technicians. If this is done extensively, many more pharmacists would be able to provide enhanced direct patient care and/or transition their practice sites to clinics and other settings. One only needs to look at the evolution of the practice of pathologists and radiologists to see how they transferred much of their time performing laboratory testing and imaging to a well-educated and trained technical staff. Now, you're all very well aware of the federal and state efforts to achieve pharmacist provider status, which also will be an additional powerful enabler. And unfortunately, I don't have time to further address that today, but would refer you to the many blogs and information on this subject, which are available to you on ASHP's website. Now let's talk about two additional enablers for change, which may not have had enough attention or be as evident to you. They are pharmacist prescribing and educating the public about the role of the pharmacist in their care. For many years, pharmacists have been reluctant to use the word prescribing, fearing that doing so would imply that pharmacists were going beyond their scope of practice. However, if you review the medication safety literature, you'll see that the prescribing phase of the medication use process is the point at which the greatest percentage of errors occurs. And computerized prescriber order entry has not been a panacea to solve this problem. Further, we have been talking about pharmacist prescriptive authority for many years. In 1983, an article published in AJHP by Glenn Stimmel used the following argument in support of pharmacist prescribing. He stated that at that time, pharmacist consultation has evolved into prescribing, and there is a need for pharmacists to prescribe. He noted that nurse practitioners and physician's assistants, whose training in medication therapy is often conducted by pharmacists, have authority to prescribe in many states, and as the need for the dispensing function decreases, new functions must be assumed. The results of pharmacist prescribing in pilot studies at that time had been shown to be safe, effective, and either equal or superior to physician prescribing. So just as Stimmel articulated in 1983, I too believe it's time to put more emphasis on expanding pharmacist prescriptive authority beyond that which exists today in collaborative practice agreements. Expanded pharmacist prescriptive authority will require appropriate training, certification, and credentialing of pharmacists granted this responsibility. Furthermore, expanded prescriptive authority should only be authorized within the context of an interprofessional team following a diagnosis by a physician or nurse practitioner. I've termed this as interdependent pharmacist prescribing. Pharmacists in clinics have complete access to all members of the healthcare team, the medical record, and credentialing and privileging processes have and can be developed. As most medications are initiated and modified in the ambulatory care setting, I believe that pharmacist prescriptive authority will be necessary to ensure the best outcomes for our patients. In time, I'll make the prediction that the pharmacist as the prescriber will become the new normal, and people will look back with surprise in the same way we do today when we recall that pharmacists in the past, before most of you were born, could not even discuss medications with their patients, but merely dispense them. Now, the last enabler I'd like to mention might be one of the most important of all. and something that we as a profession have not paid enough attention to. That's the education of the public regarding the role of the pharmacist in their care. I frequently ask pharmacists, if you were to stop 10 people on the street, a busy intersection of a city or a small town, or right here in Oxford, and ask them, what role does the pharmacist play in their care, what would these 10 people say? Well, I would certainly expect all 10 to know that the pharmacist provides them with their medications and important information about their medications. But I would bet you that many fewer than 10 could describe the advanced comprehensive medication therapy management roles of pharmacists that we have in existence today. If patients do not understand the role and value of pharmacists in their care, then they will not advocate for having pharmacists involved in their care. Many of us are faced with choosing a healthcare plan, whether it's a Medicare plan, a Medicaid plan, an employer-based plan, or many others. We always look for certain covered services. I know I look for hospitalization coverage, physician visit coverage, mental health services, obstetric services, and prescriptions. But how many patients look to see if more advanced medication therapy management services are covered, or even understand what the importance of those would be to them in their health? These services are not even listed in most, if not all, health plans. So I would suggest we have our work cut out for us in educating the public, payers, and employers about the important role that we play in patient care. Furthermore, every encounter that we have with a patient, as a pharmacist, as a student pharmacist, is an opportunity to explain and demonstrate the vital role that we play in their care. Let's now go back to the beginning, where we started today with the vision of a future where many, many more pharmacists practice in clinics, as we've defined clinics, and where every patient that needs a pharmacist has access to one. Let's talk about how we're going to achieve this vision, given the enabling factors that we have and the directions that healthcare is taking. Now, in doing so, we should also consider that not every patient needs a pharmacist at every healthcare encounter, and that the appropriate and effective use of medications belongs to and is shared by the entire healthcare team, with each member providing services within a mutually agreed to care plan. Therefore, we must develop and refine screening tools to allow us to determine which patients in our ambulatory clinics must see a pharmacist because of the complexity or other issues with their medication therapy. Let me give you some possible examples of what care in an ambulatory care clinic might look like in the future, where pharmacists provide the full extent of their care that their patients require and practice truly as drug therapy experts. Consider an ambulatory care model where one of the first providers to see the patient during the clinic visit might be the pharmacist. The pharmacist would obtain or oversee a comprehensive patient medication history and assess the patient's past response to their medications. Pharmacists would have access to the complete electronic health record and communicate with the patient's hospital and community pharmacists when necessary. The patient's detailed pharmacotherapy plan, including therapeutic goals, monitoring parameters and response, would be prepared by the pharmacist and/or updated. It would be available to all practitioners throughout the clinic visit. Conversely, other patients might be seen by the pharmacist after the physician sees that patient to prescribe based on the physician's diagnosis and findings. The pharmacotherapy plan, as part of the electronic health record, would be updated and therefore be available to all other pharmacists, physicians, nurses, and others in all subsequent sites of care. Adherence to medication therapy, early detection of adverse drug events, and earlier determination of therapeutic success or failure, I believe, would be facilitated. All pharmacists and providers would work as a team jointly to define their patient care responsibilities. Now, to prepare for appropriate allocation of each team member's time during the patient's visit, sophisticated information systems available to us today might be used to determine the entire scheduling process. For example, some patients might be with the pharmacist for most of their clinic visit. In other scenarios, the pharmacist may only be present for a short time or no time, ensuring that all healthcare providers' time is efficiently utilized and the care provided is cost-effective. In a retail clinic, such as those existing in some of our chain pharmacies and community pharmacies today, the care model could be changed to one where the pharmacist spends the majority of their time in the primary care clinic in that retail setting rather than in the pharmacy, as now presently occurs. The pharmacy would be automated and highly pharmacy technician driven. In this model, pharmacist nurse practitioner teams might provide the primary care with the nurse practitioner assessing and diagnosing and the pharmacist prescribing. Other models might include pharmacists who travel and practice in multiple small clinics or physician offices, which in themselves cannot support a full-time pharmacist. A growing number of models would be expected to use telepharmacy and telemedicine and advanced digital monitoring devices virtually connecting patients to their healthcare team and to their pharmacists. I would ask you to envision dramatic changes in our care delivery models, capitalizing on today's revolution in technology, combined with principles of disruptive innovation to design and create your future in pharmacy practice. I'll conclude my discussion by asking you to simply embrace and take ownership of a new vision for advancing pharmacy and ambulatory clinics. Become a change agent, challenge conventional wisdom, be creative and entrepreneurial, get back to your profession, and always put the patient foremost in your efforts. That is what Dr. Hartman would have expected of you and what Dean Allen does expect of you. Thank you so much for being here today. I'm sincerely humbled and honored by this invitation to give the Hartman Lecture. Thank you.